You're listening to the second season of Medscape's In Discussion series on type 2 diabetes, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Carol Wysham. Dr. Wysham is an endocrinologist at Rockwood Multicare Health Systems in Spokane, Washington, and clinical professor of medicine at the University of Washington. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hello, I'm Dr. Carol Wysham. Welcome to the second season of Medscape's In Discussion series on type 2 diabetes. Since there are so many recent advances in the management of kidney disease in people with diabetes, I thought it would be a good topic for a discussion today. And I couldn't think of a better person to review this important topic than my guest, Dr. Katherine Tuttle. Dr. Tuttle is board certified in both nephrology and endocrinology. She's the executive director for research at Providence Healthcare in Spokane, Washington, and is the co-principal investigator of the Institute of Translational Health Sciences and professor of medicine at the University of Washington. Welcome to In Discussion, Kathy.
Thank you, Dr. Wysham. It's great to be with you today and to have this conversation at such an exciting time.
It really is. So I always like to ask my guests kind of an icebreaker question. And I know that you and I are contemporaries in terms of our training and our practice and research. There's been a lot that's changed in your area since you started in nephrology. What do you think is the fundamental differences or changes that have happened in your field?
I think one of the most important things that's happened is really a turn from focusing on kidney failure and end-stage kidney disease to now the opportunity to identify people at earlier stages of disease where we have very effective therapies. So I like the concept of focusing on health rather than disease and maintaining good kidney health so that people can enjoy life and live life to its fullest.
So I'd like to start out with just a little bit of level setting because it's been a little confusing to me in the literature to see kidney disease and diabetes called diabetic nephropathy, diabetic kidney disease, or just chronic kidney disease and diabetes. What is your preferred term, or do you think there's a nuances of differences when people speak about those different descriptions?
Sure. And I really appreciate this question because I agree with you. There's a lot of confusion and there are really some distinct differences. And it does make a difference in terms of how we diagnose and treat patients. So I'll just take a few minutes because I think this helps set the stage for the rest of our conversation. So as Dr. Wysham mentioned, traditionally, during the time frame of the past 40 years or so, we've referred to diabetic complications by names like nephropathy or retinopathy. But the field has really moved forward. And originally, the concept was that nephropathy was largely a disease of the glomerulus, the glomerular lesions, the Kimmel-Steele-Wilson nodules that we learned about in medical school. Over time, as more studies were done, including biopsies of people with diabetes, it became clear that there are many other lesions in the kidney, and the kidney is structurally very complex. So lesions in the tubule interstitium and the vasculature, particularly inflammation and fibrosis, were highly prominent without another disease. So this is diabetes-related damage that's non-glomerular. And in fact, the tubulointerstitial inflammation and fibrosis is a better correlate of GFR decline than the glomerular lesions. So about 20 years ago, with the first Diabetes and CKD Guideline Committee that was formed through the National Kidney Foundation, the terminology was expanded to diabetic kidney disease, one for more common language, but two to encompass the totality of lesions, glomerular lesions, vascular lesions, tubulointerstitial lesions. About that same time, the classification of CKD came forward to measure GFR and albuminuria. And those recommendations were applied to the population with diabetes because it's a high-risk population for CKD. So that recommendation has been in place from the ADA standards of care to National Kidney Foundation, now KDIGO, and others. So as screening occurred more broadly, what we realized is we were capturing a lot of CKD some of it attributed to diabetes and some not. So other biopsy studies of these broader clinical populations showed that about a third of people with diabetes who are diagnosed with CKD have a non-diabetic form of kidney disease. The reason this is important is when we talk about therapies, we have to ask who is in the study. Well, almost nobody had a kidney biopsy. And most of the time, people are getting in by albuminuria and GFR criteria. So the truth is that we can say they have CKD and diabetes, but we actually really don't know whether it's diabetic related or not. However, the good news is that the therapies that we have that we'll be talking about apply to people with CKD, whether or not they have diabetes. But this could become important as we get to more precision therapies, where we do need to phenotype people more carefully for diabetes for specific therapies, which is a future area of research.
Well, that's very helpful. There's actually kind of a correlate to that question, and that is there's a misconception that people with diabetes who develop chronic kidney disease will first manifest with albuminuria and then only later a decline in their GFR. That is clearly not the case now. Can you talk a little bit more about that and perhaps expand on why you think that the natural history has apparently changed?
Well, I think that's, again, a multi-layered question. So first off, the original studies on natural history were done in people with type 1 diabetes. And in type 1, that paradigm still fits pretty well, usually albuminuria onset followed by GFR decline. Most people with type 1 diabetes will have a form of diabetic kidney disease. And again, I'm being very specific because it's not just glomerular lesions, even in people with type 1. They tend to follow the natural history as you described. However, with broader use of agents that lower albuminuria, for example, ACE inhibitors and ARBs, there can be a suppression of albuminuria. But what we now know through the lens of time in those studies is that the relative risk reductions for progression of kidney disease with an ACE inhibitor or ARB are really quite modest. And people progress even though their albuminuria may be suppressed, even with type 1 diabetes. So then albuminuria becomes a less reliable predictor. Although if albuminuria goes up, that's a bad sign. If it goes down, we still are not 100% sure that they're not going to progress, but it's still important to monitor it because if it goes up, then something should be intensified. Type 2 is even more complex because those people are older. They typically have other risk factors, for example, hypertension for kidney disease. And in many cases, they will have low GFR without albuminuria. And again, biopsy studies have shown us that even if they have a diabetic type of disease, they tend to have tubulointerstitial disease. So the practical take-home point for the practicing clinician is that for kidney disease screening and monitoring, both albuminuria and GFR are important. They both may be abnormal, but you can have low GFR without albuminuria and albuminuria without low GFR. That's still clinically important evidence of kidney disease that should be addressed, especially with some of the new therapies.
I think that's a really important message, is that we are looking at both, and it's either and or, but it doesn't have to be one or the other, and it doesn't have to be both. So thank you for that. What I'd like to do is just back up just a bit and talk about those patients that we're seeing that don't have any evidence of chronic kidney disease. They have normal GFRs, they have normal urine albumin levels. What are the most important things that you think we can do to help try to prevent the development of chronic kidney disease in our patients with diabetes?
So super important and critical for the community of clinicians who take care of people with diabetes. So of course, that includes endocrinologists, but it also includes really the whole waterfront of primary care. And the best thing is to never get kidney disease. I just want to emphasize that point. So you all are on the front lines of primary prevention. Number one is good glycemic control. That is really the foundation. And we know that from very old studies in both type 1 and type 2 DCCT edict and then the UK PDS study, that good controlled glycemia is foundational to preventing microvascular complications in general and kidney disease in particular. So I think that good glycemic control is absolutely the foundation. I would also say that another thing we don't talk enough about is healthy lifestyle. So both obesity and high protein diets promote the development of kidney disease. So again, this field has now some very effective tools for addressing obesity, whether they're pharmacologic or lifestyle. I think that's important. And then the other piece that I think is often attention for people with diabetes is this issue of what's the appropriate protein intake and how do you balance that with carbs and fats. And, we've looked at that very carefully in the diabetes and CKD guidelines, as has the ADA and the standards of care. And I think we've all come around to a consensus that enough, but not too much, right? And that would be the recommended daily allowance of about 0.8 gram per kilo per day based on at least an estimated lean body mass. That's enough protein for good health and not so much protein that it's kidney toxic. Plant-based diets are better. Again, we could have a long discussion about diet and diabetes, but I guess what I want to say is that high protein, low carb diets are not required for good glycemic control, and that they do come with some risk, especially if sustained over time. Moving from, if you will, diabetes care and lifestyle, I think we have to acknowledge that the two newer classes of glucose lowering agents, both SGLT2 inhibitors and GLP-1 receptor agonists, we know from populations that were studied in glycemic control studies, as well as in the cardiovascular outcome trials, that both classes of agents prevent onset of albuminuria and GFR decline. We talk a lot about the CVOTs for cardiovascular outcomes and kidney outcomes, but I don't think we've focused enough on looking at people who don't yet have complications and the evidence that these agents above and beyond glucose control appear to prevent kidney disease in particular.
Also, the blood pressure control is obviously really important. And I think you and I, again, probably remembered that first article that showed the changes in GFR slope decline in patients with type 1 diabetes with good blood pressure control.
Absolutely. If people have I don't want to say comorbid, concurrent hypertension, which in both type 1 and type 2 occur commonly, but especially in type 2, yes, good blood pressure control is foundational. And also, it's important to recognize that while we recommend ACE inhibitors and ARBs with established kidney disease or heart failure, that if you look at primary prevention in hypertension, the class of agent doesn't matter. The most important thing is the level of blood pressure control.
And what is the recommendation for prevention of kidney problems in patients with or without diabetes? At what level would you recommend we target for blood pressure?
Well, and that's a really interesting issue because it sort of depends on which guideline forming group you want to look at. The KDIGO or kidney guidelines have really pushed the lower level of less than 120/70 based on the SPRINT trial, but that was a non-diabetic population. And if we look at studies that include people with diabetes, there are some risks to overly intensive control, particularly cardiovascular events. In the big diabetes trials like ACCORD and ADVANCE that looked at intensive blood pressure control, they did not find a benefit, at least in the type 2 diabetes population. I think that most groups concerned specifically with diabetes and CKD, so that would be the ADA, standards of care, and then specifically diabetes and CKD guidelines. The recommendation has been a level less than 130/80 if it can be safely achieved. And so I think this is where clinicians are going to have to use their best judgment. And that is my best judgment. I aim for about 130/80 or less in a person with diabetes.
As those guidelines change, it's kind of a whipsaw for some of us as we think our patients are in good control, and then the guidelines change, and then you have to tell everybody, oh, you've got to, or not everybody, but we have to intensify their blood pressure management. But I think 130/80 is getting to be really consensus for the majority of the guidelines for cardiovascular disease as well as diabetes. So we addressed some of these issues regarding the pharmacologic therapies. How do you time the use of medications? Do you always start with the RAS agents as a first? And then how do you go through And how do you make a decision about whether you do a GLP-1 versus an SGLT2? Just take us through that conversation.
So we spent a lot of time considering exactly that issue in the updated KDIGO diabetes and CKD guideline that just published in November of 2022. And we also, as part of that process, worked with the ADA and along with the Standards of Care Committee, published a consensus document for harmonization, and that is published concurrently in Diabetes Care and Kidney International. So whichever family of journals you look at, you can find the paper. We really recommended what we've called a layered approach. Of course, the foundation of healthy lifestyle, along the lines of what we just discussed, then first-line therapies. And we also took a holistic view of the patient, considering the totality of risks, so not just kidney failure, but also the cardiovascular events. So first-line therapies would include an SGLT2 inhibitor with or without metformin if needed for glycemic control and if GFR is adequate. But all of the organizations now are saying that an SGLT2 inhibitor can be used alone if metformin is not needed or contraindicated for glycemic control. It's now first-line therapy, along with an ACE inhibitor or an ARB and statins and antiplatelet agents if appropriate. And then the levels of blood pressure, as we discussed, glycemic targets should be individualized. There's an extensive discussion about that in the ADA Standards of Care and KDIGO. It depends on age and the number of risks and patient preferences, but generally less than 7%. Can we say that? So then how do you layer on the other therapies? If there is persistent albuminuria in a person with albuminuria or rising albuminuria, that is the point we would add finerenone based on the trial data and the amount of data. For people who need additional glucose lowering or who have a high ASCVD risk, we would recommend adding the GLP-1 receptor agonist at that point. It's very important to recognize this is a moving target. There are big GLP-1 receptor agonist trials going on now, both cardiovascular and kidney, that if positive could change the hierarchy or allow more choices at first line. But that is currently the recommendation. I think the big elephant in the room, so to speak, is in a person that is commonly seen in a diabetes practice who may not yet be on any of these therapies is how do you sequence them? You know, the recommendation to use ACE-ARBs as background therapy really has nothing to do with effectiveness or efficacy. It has to do with the fact that those were approved for the treatment of kidney disease 20 years ago. Those were the first drugs we had, and the newest trials layered those agents on top. But if we really back up and say, if we started from a clean slate, and it wasn't an issue of timing of regulatory approvals, what would we really use first? And I think that's an unanswered question based on trial data. But that said, if you look at the kidney disease outcomes within the old ACE-ARB trials, the relative risk reductions were really modest, not more than 20% for kidney disease outcomes, substantial GFR decline or kidney failure. The comparable outcomes in the SGLT2 inhibitor trials that were given on top of those agents show a 40% risk reduction. So if I were seeing a person with diabetes who was not yet on these agents, what would I use first? This is Kathy Tuttle's opinion. I would use an SGLT2 inhibitor, and I would add the ACE or ARB for blood pressure control. And if you look at, again, the diabetes studies or the CVOTs, there were about 20% of people in the CVOTs who weren't on an ACE or an ARB, and they got the same benefit for cardiovascular and kidney outcomes as people who received them, suggesting that the dominant effect was from the SGLT2. But you have to consider that that's retrospective, exploratory, and opinion-based.
Yeah, that's very good. And actually really helpful, I think, for those of us in the trenches seeing these patients. Just quickly, can you comment on what you think is the lowest GFR that you would suggest that those of us who are not nephrologists could consider starting an SGLT2 inhibitor, and what is the follow-up you would recommend?
Yeah, based on the current evidence, GFR as low as 20. And that's from both the heart failure trials, IMPA preserved and IMPA reduced, and now IMPA kidney. And in IMPA kidney, which I guess is most relevant to this conversation, we saw comparable benefit across the GFR range. So even people with a GFR as low as 20 benefited. And that's for initiation. People then say, when should you stop? Those trials did not stop the agents until people required kidney replacement in the form of dialysis or transplant. And there's actually now a trial going on in Europe looking at people with GFRs less than 20, including people on dialysis and transplant, where the primary outcomes are heart failure outcomes, not kidney disease outcomes. So we don't know the results of that, but that's just to say the field has moved lower and lower. And currently, you could initiate as low as 20, and depending on the results of those trials, it's possible that that limit could go even lower.
If a GFR drops by what percent would you be concerned about continuing the medication, or is there a level that would cause you concern?
Sure, and that was another really important point of discussion in the guideline process. Again, consensus between ADA and KDIGO is up to a 30% drop is expected. That is thought to reflect a reduction in glomerular hyperfiltration, which over time will be kidney protective. And in fact, there are studies that show that people who have the GFR dip actually do over time have even more preservation of kidney function than people who don't. So you can almost think of it as a readout for a therapeutic response. If it declines more than 30%, then that's the point to stop the agent and reevaluate what's going on. Sometimes people have low blood pressure because SGLT2 inhibitors can drop blood pressure, or some people are highly responsive in terms of diuretics response. And if they're on concurrent diuretics, those may need to be adjusted. But even if you stop temporarily, make those changes and then reinitiate therapy.
That is incredibly helpful. Thank you for that. So really quick, how do we address the issue with comparing the kidney outcomes with the steroidal mineralocorticoid antagonists versus the newer non-steroidal mineralocorticoid antagonists? I'm getting some prior authorizations that they want me to try the older ones first, but do we have any kidney outcomes to suggest that they have benefit?
Unfortunately, we do not. They are indicated for heart failure, which might be where some of that pushback is coming from on the pre-authorizations. For spironolactone and eplerenone, there is evidence that they reduce albuminuria or proteinuria, but we don't have any kidney disease outcome trials like we do with finerenone that showed clear benefit. And the other issue is a safety issue, is that there have been head-to-head comparisons of those agents with finerenone, and they're much more likely to cause hyperkalemia, which is a really important safety issue, especially in the low GFR population. So the preference really is for finerenone, both for safety and it's where we have the outcomes data.
Thank you very much. Well, today we've talked about a lot of issues regarding diagnosis of kidney disease in patients with diabetes, of prevention, importance of choosing appropriate medications, blood pressure control, lifestyle issues, but also kind of what considerations that we should give in terms of determining which of these renoprotective agents we should use. And I think it's been really helpful. And I want to thank you very much for your insight into these issues. And I want to thank the audience for joining us today. This is Dr. Carol Wysham for In Discussion.
Thanks for listening to Medscape's In Discussion Type 2 Diabetes podcast series with our host, Dr. Carol Wysham. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com or the Medscape app for show notes, links, and more information on type 2 diabetes.